Okay, my name is Donna Aldridge. I work at Dakota Counseling Institute in Mitchell, and they were asking for volunteers to talk about what is counseling, and I think a couple of other subjects. But when I looked at the one that said, what is counseling, I'm all over that. So I immediately volunteered, and I don't know who else did or whether I was the only one, but I got it, and so I'm here to talk about it. I was a little unsure about what kinds of things to put in the PowerPoint. So, I just thought, since this is a pretty informal meeting, we would just, take a look at what the general public sometimes thinks a therapist is. This is a grow your own therapist. He won't judge you. It's drug-free. He's the only shrink that grows. Happiness is for everyone. So there's a lot of stuff that you hear in some of the funnier online things about what therapy is all about. And this is, a grow your own therapist. There's a ton of initials. When you start looking for a therapist, the very first thing you're going to find is all those initials. And the South Dakota Counseling Association does a really nice job of listing even more initials that I don't even have up here. Behind my name, there's an MA, and then an LPC, and then the QMHP, which means that I did my 60 hours of graduate study and got the MA, and then that included about 600 hours of therapy time, direct therapy time. And then I used that to go for more supervised therapy time. You have an year of internship, and then in order to get your license, you still have to be supervised and pass a test and all that kind of stuff. And then another test for the qualified mental health professional, which in South Dakota makes you the person that gets the emergency phone calls and does the assessments for people who might need to be hospitalized and they don't necessarily want to be hospitalized. And that includes a risk assessment for suicide, but also a risk assessment for harm to others. So those are some of the main things that they do. I wanted to go through these because there's just so many of them, and if anybody has questions, don't hesitate to ask. The other reason I wanted to put them up here is that your counselor may come from different areas of study. They're not vastly different, but for example, I have a master's degree in psychology versus a lot of counselors have a master's of social work. They may have a master's degree directly in counseling. Sometimes they go through the Department of Education. And sometimes you'll see this marriage and family therapy, which means they had additional hours that they had to go through in graduate school for couples and family sessions. And it's a pretty big deal with the MFTs because they have a lot of extra requirements to finish with that. And I know because I did it all except the last class. Naturally, I didn't finish. It was just one of those things. I would have had to have been in school for a long time, and I did an extra year because of scheduling. So it's a wonderful program. I have used that knowledge many, many times and feel really comfortable with it. But I just do community mental health because I love to see all kinds of different people. And in community mental health, you get to see the gamut from things that are just kind of, I can't sleep at night, to major panic attacks, to severe depression, to schizophrenia. We get to see everything in community mental health, and every day is a new day, and that's what I really get excited about going to work for. A healer, which is in this context going to be talking about a therapist, is not somebody that you go to for healing. A healer is someone that triggers within you your own ability to heal yourself. One of the biggest fears that I hear from clients coming in is Essentially that I'm going to read their mind and that I'm going to see way down inside of them, maybe to things they don't even see themselves, and they're very scared. So one of the very first things that I do is remind them, I will never know you as well as you know yourself. You get to be the expert on you all the time. No therapist. They can suggest, and maybe if it's something you haven't thought about, you think, oh, well, that's probably true. But they don't crawl inside your head and figure out all your secrets. They only know what you tell them. And so you get to decide what you say and what you don't. When you choose a therapist, naturally, as somebody who's licensed, I'm looking at, you want to go with that license, but there are ministerial counseling services. Now, LSS is all qualified in terms of degree and license, but a lot of ministerial services are pastors who do pastoral counseling, and there's nothing wrong with that. You know, if that is where a person is most comfortable, then maybe that's the place they want to start. It's not a competition to say, oh, you've got to come to me because I'm better. It's not like that. It's wherever you go that you can get the help that you need. So if that's more comfortable to start, that's where you start. And if it works out, then it works out. If it doesn't work out, then you've got some other information and there are other choices. The therapeutic relationship, the relationship between you and the counselor that you choose, is the single most important thing in terms of whether you will get what you want from therapy. No matter what treatment modality, which I'll talk about in a minute, no matter what this person has studied in school, no matter how long they've been a counselor, it does not matter. And I'm distracted now because there was a flash. It's okay, I just lost my train of thought. It does not matter how qualified someone is if the relationship with you is not comfortable. You have to be able to say whatever it is that you want to say. You know, therapy is not effective if you can't just be there. So that's the one thing that's the most important. And all the research bears that up year after year after year. They study, you know, is CBT the very best therapy? Well, if you have a good counselor, sure. Is another therapy the very best therapy? Well, if you have a good relationship with your therapist, absolutely. So I always want to really emphasize, you are not stuck when you've chosen a therapist. If it's pastoral counseling, hopefully you can have that dialogue with the pastor about whatever else it is that you think you might need or that you want to check out. As a professional therapist, I will tell you that if you're not satisfied with me and you don't think that we're going to accomplish anything, I would so much rather you tell me. Number one, it's possible, and it has happened, that I can absolutely change an approach. You know, I'm going a particular direction because I think that's the one that's going to work, but if you tell me it's not and we discuss it, then maybe I can choose something that will. Secondly, as a professional, knowing that that this relationship is so important, I will try not to take it personally, and I want to know what you're looking for because I'm in a unique position to know lots and lots of other counselors, and maybe I can refer you to somebody that'll be a perfect fit because I know what you're looking for. So if you're not satisfied with a therapist, if you get inside the door and you're not satisfied, don't feel like you're stuck. There are options to change the way you're approaching this therapy or options to change to another therapist. And don't hesitate to talk to your therapist about it. Hopefully they will be professional and take that as something that they can do to help you, guide you in the right direction. It should not be a personal kind of a thing. Let me see. One of the reasons that now with a minister, you kind of expect that you're going to have some confidentiality. your relationship with your minister is going to be the one that tells you whether that's going to be the case or not. But for an LPC or an LPCMH or somebody with that master's degree and that license, the code of ethics is absolutely unbreakable. If you get reported for a breach of confidentiality, even one, there is a good likelihood you're not going to keep your license. The code of ethics also has a thing in there about competency. If you come to me for CBT, which again I'll talk about in a minute, and I am only interested in giving you some other form of therapy because I don't know anything about CBT, but I say, sure, you can come to me, and I'm trying to do CBT, that's outside my competency. And that's an ethical violation for me to attempt to do something outside my area of expertise. Now, in a rural area, sometimes you don't have a lot of choices. So as long as your therapist is honest with you and the two of you are going at it together, you can try anything you want to try. But a therapist cannot try to tell you that they're competent in this area if they have not been trained and not studied in that area. So out of all of the code of ethics, those are the two things that I picked out. And if somebody knows something that they feel like is just as important as these two, then don't hesitate to holler it out. But those were the two that I felt like what happens in the therapy room should stay in the therapy room, and your therapist should be competent in whatever it is you're pursuing in that room. And that's how I would judge just that basic.
The only thing I maybe would add is about the confidentiality, the limitations on that.
Okay.
So everybody's clear on that.
Okay.
See a therapist.
Okay. There are limits to confidentiality, is what he's talking about. And if you come to me and tell me that you are going to kill your spouse, you have a plan to do so, and the intent to follow up with that when you leave the therapy room, it is my duty to break confidentiality, warn your spouse, and contact the police, and probably do an involuntary hospitalization because you are now a danger to others and you have made a commitment to that threat. If you threaten to commit suicide and you have a plan, and the plan is lethal, and you intend to complete that plan, once again, I have to break confidentiality. In other words, safety of the client and the clients and others around the client is always the first duty. You cannot allow somebody to leave your office with an intent to kill somebody and not warn. And there are legal cases that back that up. You also don't let somebody leave your office and go commit suicide, which is, again, I mean, it's not an ethical thing to do, but just it's not healthy for anyone. So you've got to protect people sometimes from themselves, and those are limits to confidentiality. There is also no law that allows a therapist to withhold notes and information in a court if a judge subpoenas it. Now, we get around that a little bit by, for instance, my therapy notes are very vague. They say that you were there on time, that you were nervous or you were relaxed. They say that we did, we had agreed to focus on depressive symptoms at our last session, and that's what we did. And it might say the therapy was cognitive behavioral therapy techniques such as validation, reinforcement, and reframing. And then it'll say we agreed to continue talking about this at the next session. And that'll be my entire therapy note, because if it were ever to be subpoenaed, I'd have to give it up. And in order to maintain confidentiality, I don't want to put too much information in that note. So those are, did I miss anything? Those are the exceptions to confidentiality. If you overhear your therapist in a restaurant talking about you, report them in a heartbeat. Don't mess around. Go right to the state and report them, because that is a huge deal. And it gives all of counseling a bad name. So, you know, when I start a therapy session, I typically start it with my philosophy of life / therapy, and that is that no one wakes up in the morning and says, how can I screw myself over today? We do the best we can at any given moment. If we could have done better, we would have in that moment. Even if you have great choices and you can think of a better choice after the fact, maybe you were so excited that there was only one choice in that moment, you're still doing the best you can. So we're going to look at that and try to make sure that you're not feeling judged, and what is it that you need to do next, either to make it right or to feel better about yourself. People judge themselves so harshly that that's the way I like to start things off. You own the therapy hour. It belongs to you. And so it's your agenda and your treatment plan. You know, treatment planning is a thing that sometimes comes as a surprise to people when they come in. You know, what do you mean I have to have a treatment plan? I'm here to talk about this. Well, most community mental health services and other counseling services that have, if they take insurance, they have to do some sort of treatment plan to justify why you're in there. It may be shared with the insurance company, or it may not, but there has to be one. I like to tell, I couldn't believe I found this, because this is the joke I always tell at the beginning of therapy. How many psychologists does it take to change a light bulb? Well, it only takes one, but the light bulb has to want to change. So if you come in to see me because your wife says you have to do this or else, my first question is going to be, do you want to do that? And I need an honest answer, because if you don't, we're really wasting our time. Unfortunately, I see a lot of adolescents that fall in that category, and you work with them a little bit to see if you can motivate them to change. Wouldn't you like to be in less trouble? You know, wouldn't you like to graduate with your friends? But if you can't get them to commit that they want to do something differently, then even at that level, you're kind of wasting your time after a while. You plant seeds, and hopefully the seed will find a fertile ground and germinate and grow, and things will be wonderful. If not, maybe that seed will stay there, and at some point in the future, when the conditions are right, it germinates and grows. So that's all you can do as a therapist. So what do you want to change? The analogy I use is that if you want to go to California or to New York, if you want to go to New York City, I will get a map. And my office is like lined with books all the way around, and so it kind of looks like maybe I could find a map. If you want to go to New York City by way of California, I'm going to say, you do know that that's like thousands of miles out of your way, don't you? But if that's what you want to do, I will get another map. I will ride in the car with you the entire time, but I will not choose where we go, and I will not drive. That's on you. I like to do this at the very beginning because sometimes people feel like they're coming in and the therapist is going to fix it. And the therapist doesn't fix it, you fix it. The therapist finds a map to help you fix it. And that's what the treatment plan is. Something that you can actually count and see Well, on a scale of 1 to 10, my panic attacks are a 10 every time. And can I get them down to an 8? Something that you can concretely hold in your hands and see. There's a big push out there with insurance and all that kind of stuff for what they call evidence-based therapy. Evidence-based therapies, there's lots of them. There's a list that the federal government puts out. Some of the big ones are cognitive behavioral therapy, systematic desensitization, which is a specific protocol that people use to try and help individuals who have a phobia, of spiders. Or one of the nicest examples I've seen in the last few years was a colleague of mine worked with a woman who had been in a workplace accident, and it was pretty serious. Fortunately, she recovered well, but she'd get to the doorway of the company and start to have panic attacks. She wanted to go back to work, but she was so afraid. So a systematic desensitization program was what was employed to slowly help her make her way back past the lobby, past the door, into the work area, back to the machine, maybe starting the machine. You have to go slow, you have to go at the client's pace, but that's an evidence-based therapy. In other words, it's been proven to be effective more often than not. Dialectical behavioral therapy is a great big package of group and individual work that is listed in the evidence-based therapy. It has to do with trying to understand that it doesn't have to be either or, it can be both and. Two things that may not seem like they agree with one another can both be true. So that's a super simplified explanation. Trauma-informed therapy is the up-and-comer in evidence-based therapies, based on a lot of people who have problems later in life. Actually, it's a result of the difficulty level that they're at now is often a result of trauma that happened years before, either in childhood or in adulthood, or as a response to whatever they're coming into therapy for in the first place. And there are different ways to approach that than cognitive behavioral therapy, for example, which has been shown not to work with trauma patients. It's still out there for the insurance companies, but it does not work well with trauma patients. CBT is the #1 thing that the insurance companies like, so I thought I would try to just very briefly explain what that's about. It works on the idea that your thoughts influence your emotions, and the two of those things influence behavior. Now, there are some models that also show that behavior reinforces thoughts, and so that's why it's a circle. But the idea of cognitive behavioral therapy is that you can actually separate each one of these things. If I change my thoughts, it will change my emotions, which means my behavior will be different. And they use that model for depression, for anxiety, for all kinds of different things. The idea is, I always use the example of the high school students who are walking down the hall with their books, and you see your best friend and you wave, and they don't pay any attention to you. And you think, what did I do? Why is she mad at me? And you spend the rest of the day churning on what in the world happened. And the next time you see her, you're like, I'm not talking to you either. So the thought was that she was angry. What if you find out that she was concentrating on a test that she was very worried about, and she didn't even see you? So the therapy is all about reframing what the client perceives. Perception is reality, so you have to work on that. And then you say, so if you think about it this way, how would you feel? Well, that would be fine, I wouldn't be upset. So your actions, I'd be very supportive instead of turning away and refusing to talk to her. And that is basically the principle under all of CBT, no matter what you're discussing. It is, you know, trying to do that part of it. Well, I got lots of time. I went ahead and included in here, you know, in addition to the idea that you can seek pastoral counseling, there are other ways. They're not going to be the same. My emotional support animal, 4 legs and wags his tail. When I get home, my dog is so excited to see me. Last time I put her in a kennel to board her so I could take a trip. I walked in and she's just on the leash. She saw me and it was literally, I had to catch her. She leaped right up into my arms. That kind of love that you get from an animal, that total acceptance, you don't get that just anywhere. And it is absolutely a wonderful thing. If I could write a letter supporting emotional support animals for every single person I ever see, I would do it, because I think it's that big of a deal. And maybe that's all you need. But if there's more, if it's somebody that you need to talk back and help you to figure things out, then that's going to be a professional therapist. Your emotional support animals will only go so far, basically because they can't talk, although this one does. And they're just really, that's like my dog, just a little frenetic. Wait, yeah. She just gets really excited and she's hard to control. And so it says beware of emotional support dogs. Honestly, that is not the case. They are wonderful as an adjunct and maybe for as all somebody needs. I also wanted to say a word about medication. People have as much of a barrier to wanting to take some kind of a med, an antidepressant or an anti-anxiety pill. Those things are not to be shunned automatically. They're not a sign of weakness. I'm a diabetic. Once a week, I'm not insulin dependent, but I take a medication that I give myself a shot 1 time a week. So that keeps my blood sugars under control, helps me regulate my weight. My pancreas does not work like it is supposed to. And if I don't take that medication, my blood sugars will go up and it will damage my heart and all of my other organs. Even with your blood sugars under control, sometimes diabetes gives you problems like visual problems. The super dry mouth causes problems with teeth. It's just a crazy kind of a thing. I would never want to go without my Ozempic or some kind of medication to help control that. If you're depressed, clinically depressed, that means that your brain is not giving you serotonin. My pancreas doesn't emit the right amount of, what was it I just said? Insulin. Yeah. So there's no difference whatsoever in whether or not you're getting enough serotonin or getting enough insulin. With the brain, when things happen, and maybe especially if they spiral and 2 or 3 things happen, then either the brain doesn't produce as much serotonin, or it produces it, but then it says, oh, wait a minute, let me take that back and recycle it. And so it doesn't allow you to use it. It is possible, if the only reason for depression is outside events, that your brain will get the message that it wasn't doing its job, and 6 months to a year later, if you go off of the medication, your brain will say, I know how to do that. Serotonin, here you go, and everything's good. Sometimes, people who are right on that line before they're diabetic can sometimes control things with diet and change things and not get that final diagnosis and go over that edge. if it happens that maybe there's a history in the family of depression and your brain is just not gonna produce enough serotonin to keep you out of being depressed, you may be on it, but there's no difference in that maintenance than there is in taking Ozempic or taking something for your heart or anything else. So I just like to throw those things in. Sometimes a therapist will recommend that you see a psychiatric provider or somebody for medication, but counselors don't provide medication. You know, that's one of those big differences. We are not licensed to provide medications. We sometimes know quite a bit about them, but we have to be really careful because that's not our area of expertise, and we don't want to be practicing outside our competency. So, you know, I'm not gonna say, well, I like Zoloft, which I do, and I might be able to say that, but I'm gonna say that's a personal thing, and your doctor knows your body and your chemistry. And these days there are DNA swab tests that can help pinpoint what medication is the best medication for you. Sometimes that happens and sometimes it doesn't, but it's an inexpensive DNA test to match medication to who you are. And it's worth a try. If I were gonna do it, that's the first thing I would do to see what came up. And I was going to finish with a wonderful little video from the Missouri Agriculture Department that had a whole bunch of farmers singing to the tune of YMCA about going to therapy and how it's not a terrible thing and don't be ashamed and that kind of thing. But I could not get the link to work all morning, and I don't know whether they've taken it off the website or if I just have a bad link, but I would try the Missouri Extension Service and see if it comes up because it's a lot of fun. And I have lots of time left, almost 20 minutes. Does anybody have any questions? Yeah.
From a farmer standpoint, you know, what are some of the indicators that, you know, you're getting to the point where you should seek some counseling? Or how do you know personally, you know, because that's what the guys, I mean, they don't want to go.
Yeah, no.
And they don't want to admit that they probably need to go. So
Yeah.
how, you know, what are some indicators that, you know, that it would maybe be beneficial?
Okay. Depression can sometimes fool people because sometimes you're incredibly irritable. You don't moan and whine around and lay in bed necessarily because you got things you got to do, but you get really snarky and a little mean, and you say things that you don't necessarily mean. You hurt your loved ones because you've just got so much anger and despair that you can't share, and you're stuffing all of that down, and it comes back up as, why did you do that? I told you not to do that. And maybe it's a little stronger than that. So a lot of irritability is a big sign that, especially if it's not your character. Are you a guy who's pretty relaxed and laid back? Then irritability is a big red flag that it's time to do something. If you don't want to get out of bed, and it is absolutely a struggle, your thoughts are going, what difference does it make? If I just stay home today, it's not going to be that big of a deal. I probably can't get into the fields anyway. If you're avoiding, if you've got no energy, those are big signs of depression. If you are sleeping more than is normal for you, if you're sleeping less, depression does not have to be by itself. Depression and anxiety often go together. So you can be very depressed and not wanting to do anything, but also very anxious with lots of energy that you're not burning off. And so one side of you is going, do something, do something, do something. And the other side is going, I don't know what to do. There isn't anything that I can do. And that frustration and can be absolutely overwhelming. Depression and anxiety together is another thing, you know, to look for. There is a great story, it's actually a book, called Why Zebras Don't Get Ulcers by a guy named Sapolsky, big doctor out in California, lots of neuroscience kinds of stuff. And the premise of the book is that we have the exact same old brain system that a zebra has, or any other animal for that matter. The zebra is just grazing on the plain, minding its own business, and a lion jumps up. Well, that zebra immediately has cortisol and adrenaline and energy, and everything is popping inside that zebra, and he is not even thinking, he starts to run. And if he can't run, if he's someplace where he's in a wall, he flips around and he fights. And he either outruns that lion and gets away, or outfights that lion and lives, or he dies. If he wins, if he gets away, he stays a little fidgety for a while, trying to make sure that there's not another lion. But he has spent all of that cortisol and adrenaline that flooded his system. He spent it running or fighting. And it doesn't take terribly long for him to start to really settle down and relax again, and he goes back to grazing. Now, if we open the door and a lion jumps out, we have the exact same reaction as the zebra. But let's say you open the door and it's the IRS. Still have the same reaction. System gets flooded with cortisol and adrenaline, and it has no place to go. Now, if you're somebody who goes to the gym, you can try and go and get on that treadmill, but your thoughts keep coming back around to the fact that the IRS is auditing you. And did you do something wrong? And how long is this going to take? And what's going to happen? And is it going to cost me money? You don't have any place to put the amount of cortisol and adrenaline that is rushing through your system. So it can turn around and start damaging your body. And that's how you get ulcers. There are other anxiety-related diseases. It's another good symptom for farmers to think about is if you start feeling aches and pains to a greater degree than you have in the past, then you might want to kind of just make a note of that. In your brain, over here in this limbic system, the same organs in the brain control almost all of the negative stuff. It's a left side and a right side, but right side is more negative and more dominant for danger situations. And what happens is that because you're anxious, your pain level, you've had arthritis for years, but all of a sudden it hurts more. And that's because the same part of the brain is aroused from the anxiety, so the pain is more. If you're also depressed, the depression is more, and these things feed each other in a bad cycle in there, and that's a big key that things are getting out of control. Physical pain level is not something that people associate with anxiety and depression, and it's a good place to put your feelings if you don't want to talk about them or you don't think you can talk about them. A lot of times people become very much the victim of chronic pain. If you're trying to avoid things, it's easier to say, well, I can't even hardly move today because my arthritis in my hip is so bad. That's a whole lot safer to say for yourself, for your self-esteem, than to say I'm too depressed to even want to get out of bed. So that's another big one. That side of I like to it's super oversimplified, but the left side of your brain is the happy side. And it's kind of like, let's go play in the street. Doesn't that sound like fun? And the right side of your brain is over here going, don't step off the curb. You could get hit by a car. Well, we have this thing, this corpus callosum, where the left and the right side talk to each other, and they decide, I bet we could go to the park and play. We might have to cross the street, but we'll look both ways. Problem solved. But the right side of the brain, because it is so attuned to any kind of danger, it has the power to hijack all of your thinking. So when you open that door, and whatever it is that you're afraid of, or whatever it is that shocks you and surprises you comes right there, then this little amygdala says, I got this, you don't have to think. And it literally just takes over. And you may not be able to talk, you may not be able to do anything. You may be, my mom, my poor mom, she gets scared like that. She doesn't even make a sound. She runs in place with her eyes closed. I used to hit, so I trained myself not to over lots of years, because my first impulse was always, and I broke a window, and don't scare me. I don't hit anymore, but I make a lot of noise. And one time I did a nice duck and cover in a parking lot at Menards. It was embarrassing, but I don't hit out anymore. But you don't think, the guy who's hollering at me that scared me so bad is saying, do you want help with that? All I heard was somebody was there that I didn't know was there. They're yelling, and they could hurt me, or whatever it was. There was just no thought there. I reacted to it. And that's the power of the amygdala and the right side of your brain. So it tends to amplify danger and amplify bad things. It's catastrophizing, If I have a little spot on my arm, it's cancer. I tend to go right there. One little thing that goes wrong, I catastrophize it. And that's a right side mechanism. And that cognitive behavioral therapy, if I rethink it, well, shoot, I hate to admit it, but that's an age spot. That's not a cancer. Maybe I should have the doctor look at it just to be sure, but it doesn't have to be the worst thing that ever happened to anybody. That's kind of that reframing that cognitive behavioral therapy is all about. All right, I wandered all over the place, but do you feel like I answered the question? Okay, that's important. Anybody else have questions? We have about 10 minutes. I could sing and dance.
So I don't know where we have this background. I'm a grad student at USD.
Mm-hmm.
Dr. Olson's my advisor in the counseling department.
Mm-hmm.
I think I was kind of wondering is, if you were to give just a 2-minute kind of what we call elevator speech to a farmer who asks you, what is counseling?
Uh-huh.
How would you kind of summarize that? Because I kind of would like to work in a rural area.
Mm-hmm.
My family's farmers, but I have a really hard time telling them what it is I want to do.
Mm-hmm.
And explain, like, this is what we do.
Yeah. So in my first counseling session is when I usually meet people, and I do it, kind of the way I described. I tend to do more talking than the client in that first session because orientation is important. And they a lot of times don't know what they're getting into. And so I'm gonna kind of describe the process. And I want their feedback, because since it's their hour and their therapy and their desire, I need to know what that is. And so I need to set it up so that they know. A lot of times they can't tell you, but it gets them started thinking. And That's the important part of it. Now, in an elevator, can we go like from the bottom floor up to the 50th or something? What I would say is you might be surprised at the people who wind up coming to therapy. It is not about being crazy. In fact, your therapist is probably gonna really encourage you to see that you're not crazy, that what you feel is perfectly understandable, and you're in charge. You're there because you have a specific problem coping with something, or you don't like the way you feel about something. You know, two of the nastiest words in the human language are should and must. And if we could drop, I mean, who made that rule? Who made that rule that you should do this and you should do that? And who says you must be this and you must be that? If you got rid of those two words, you'd have a whole lot happier population. And you'd think things through more clearly because you wouldn't be, bam, all over. I use the word aroused because it's a nervous system word, but you wouldn't get all over aroused in the first place because you're down here thinking analytically instead of bam on the emotions. So that's kind of what I would say probably. More. I think, I'm a counselor, so they all say everybody could benefit from counseling at some point, and there's probably truth to that. But that also is kind of an old-fashioned way of describing therapy back in the psychoanalytic days where, I mean, you see this stuff on TV and you don't even know that even that is not exactly accurate, but they did have a couch, but they would sit with their back to you because the idea was anything that you showed on your face could influence that client. And so you were not gonna look at them or answer them or even do very much talking. It was about them just, taking off and talking, and the therapist just sitting there, and that's about it. And so it also took years. Sometimes they were more directional, especially after therapy really started to grow. You started getting more people doing more things in therapy, and but psychoanalysis to this day, you're expected to be in therapy for a couple of years at least, and you're exploring who you are inside and how you respond to things. It's not practical. And I can't even imagine if that is the idea that people have, that this is what therapy is. No wonder they don't want to come. They don't have the time or the energy, and they've got stuff they need to do, and they just want it fixed. It's not quite that simple, but it doesn't have to be hard either.
Is there a best way to get someone to go to counseling?
There is a thing that counselors ask each other in marital therapy or family therapy, and that is, who is in distress? Because that's your patient. And if you're in distress and they are not, then the therapy has to be directed at you. Does that make sense? You have control over you and only you. And in terms of making somebody else do anything, just never gonna happen. Now, can you provide information and support? Absolutely. But even if you had the power to say, you're going to go, and they go, doesn't mean that they'll do anything when they get there, because they don't want to be there and they don't want to change. So, does that answer your question? I don't want to be discouraging, but at the same time, you know, we do that a lot. We look at other people and they should do something or another, and we don't have that kind of power, first of all, to even decide what they should do. When you come right down to it, you don't know what's going on in their head. But secondly, it's a exercise in frustration, because you don't have that kind of control over another person.
Do you find that more people come to you willingly or unwillingly?
Way more willingly. I work with drug court, and so I get quite a few referrals from drug court, and sometimes you'll get a probation and parole, or you'll get a kid who's on court services, and they'll come in and they're there because they have to be. And I'll tell you honestly, what I try to tell them is, this is your hour. It's not your probation officer's hour. It's not an hour that belongs to drug court. It is not a time where I'm going to lecture you about whatever it is you've been doing. What do you want to do with this hour? And if they have no idea, I might show them a treatment planning book that has different things in it that you can work on. I might do career planning. There's an incredible amount of very positive therapy that you can pull in to career planning with somebody and looking at what they want to do with their future. And hey, what a motivation to a kid on CART services. If he wants to be this or that or the other, he better pull himself together or he's not going to get there. So I try to help them find something that they're not wasting their time about. So even if they're forced to come, I want to make it a therapeutic experience. And I want to remind everybody that they're in charge of themselves. And what I tell kids is, you know, I encourage you to control yourself, because if you don't control yourself, somebody else will. And you probably won't like it.
And with what I do, most people are in front of me almost unwillingly, so it's like it's interesting to hear when people are willing to do it, but I'm a mediator.
Yeah. I did all that training when I was back. I'm from the South. Sometimes I get excited and I forget that there are words that you don't say up here that we say down there. But I did that training in Missouri, and it was almost entirely attorneys, and they didn't get it.
And I'm a non-attorney mediator.
Uh-huh.
I'm the only South Dakota farm ag finance mediator. So I deal with every farmer that is going through the farm crisis and having trouble with the bank.
Mm-hmm.
And most of the time they're unwilling.
Yeah. Mediation is trying the best you can to find a solution that nobody's happy with, but everybody can live with. And, you know, back when I would do some of those cases, it would be pretty much up front. I don't want you guys to have to go to court. Typically, I would do that with custody cases and stuff. And it would be, I don't want you guys to have to go to court and have a judge decide this. So let's figure out what we can do here to head that off, because nobody is going to like it if the judge decides. And that's where we would go from. And some people will do it and some people won't, you know. And you don't have the same options I do, because you have a specific thing that has to get done, and I don't have to do that.
One nice thing is I don't have to make the decision. still up to the parties.
Hmm. Yep, and that's a thing that you can absolutely push to help them feel like it's their time and not your agenda. But yeah, same thing in therapy. I can't make you do anything, and I don't want to. You know, my purpose is to sit back here and help you decide this or this by thinking about both things completely and seeing which one it is you truly want. Now, I have a woman who comes in and she's all fired up about something, and I'll say, yeah, you could do that. She says, this is what I want to do. Absolutely, you could do that. Is that going to get you what you want? And then she backs up, you know, because actually has not going to get her what she wants at all. Might satisfy in the moment, but in the long run, it's not what she wants. Does that help? Not so much.
For me, yes.
Okay. All right. Woo! It's 2:01.
Well, thank you.
Thank you.